So, hello everyone. My name is Ratuja Campbell and I'm the founder of Basic Surgery. Welcome to our Trauma and Orthopaedics webinar. And this is hosted by the fantastic Mr. Simon Fleming, otherwise known as OrthopodReg on Twitter. So before we start, I've got a couple of technical points I just wanted to let you know about, whether you're viewing us via Zoom or via YouTube. We have the chat function and the Q&A function in order for viewers to post any questions that you want to ask at the end of the webinar. If you do have any technical issues, then just post in our chat function and we'll get back to you. So without further ado, shall we start, Simon?
Yeah. Is my sound working, Ratuja? We good?
Yeah,
awesome. My name's Simon Fleming. I'm an orthopedic registrar in London. I do loads of other medical education stuff, and I'm currently doing my PhD in medical education. And allow me to congratulate you all on being super keen and coming and learning some orthopedics randomly on an evening. So this is generally the blurb and says that you're going to have a quiz and stuff's going to be recorded. All the usual kind of terms and conditions apply. The goal today is to be able to kind of recognize, discuss and manage some orthopedic cases and to make sensible referrals. What I would say, and it's not to make an excuse, but orthopedics, like any specialty, is an extremely broad topic. And I had to make a decision about whether I covered lots of things really superficially, some things in a certain amount of depth, or like one thing properly. And I feel like that for today, what you want and what I can give you is to cover a couple of common orthopedic things in enough depth that you go, oh, I get it. The kind of take-home disclaimer is, and I'm going to cover this a lot, but honestly, as an orthopedic registrar, it's a thing. Please don't be afraid to contact your senior colleagues. I would always rather a bleep, a WhatsApp, a call than to not be and come down and find you struggling, or find you being given a hard time by people, or just you feeling like you were drowning. And part of the challenge there is, certainly in orthopedics, but there are other specialties, is we're often very busy, either in theatres or in clinic. So you just need to let us know that you need a bit of support, because by definition, we're not always on the wards. These are the kind of aims of every webinar that Basic Surgery do, and they're pretty good aims as aims go. This is the QR code for the little quiz that's going to be at the end. I'm just going to leave it here to allow for the lag that is the joy of the internet. But for those of you who are going to do the quiz, this is the thing. So the first question is, what is not a principle of open fracture management? The second question is, oh, do you need me to go back? See, multitasking. This is because there's a lag, because internet. The second question is, how will the leg commonly present in a neck of femur fracture? The third one is an early sign of compartment syndrome. The fourth one is an anatomy question. I regret nothing. And the fifth one is just a really simple management question of a broken ankle. The other thing I tried to keep in mind, on top of the fact that hopefully this is going to help you with your on calls, is that orthopedics, one of the best or worse bits of orthopedics, depending on how it's run and how it's done, is every morning we have something called the trauma meeting. The trauma meeting is like an MDT meets a PBL meets a case-based discussion all at the same time. And so a lot of the stuff I'm going to cover often gets either asked about or quizzed about of a trauma meeting. And so these questions are like common trauma meeting questions as well. There are a lot more, but just like the general surgeons are like, tell me about the inguinal canal, we do love these questions. So what I would say is the joy about orthopedics is I honestly think that it's the most rock and roll specialty out there. We get to fix people. We get people who come in with these injuries that you look at and you can instantly be like, oh my God. And then very easily we sort people out. When this came up on Twitter, about a bazillion Twitter orthopedic surgeons were like, I think you need to know, Tony Hawks, that you're officially now in every teaching presentation I will ever give. And it's literally like a promise I've made myself. So what I'm hoping to cover are a little bit about trauma. Again, not a huge amount of detail. Then some hips, ankles, wrists, open fractures, and compartment syndrome. But that's to put it in context that this is only adult orthopedics. I'm not covering the whole body. I'm just going to cover some really common stuff that comes in day to day on your average on-call. So the thing to know about trauma is that it is 50% of the orthopedic workload. Trauma is by definition just not the elective stuff, not the stuff that we're doing planned. And whether it is major trauma, like the picture here with the patient with blast injuries, or what you might consider, or what some might consider minor trauma, like a broken ankle, it is still trauma. And it means you're going to get called to see the trauma calls, the big rock and roll stuff that come in by helicopter. And to be fair, every other bit and bob. What I would say is, and this is something that I learned early on in orthopedics, is you kind of get desensitized to trauma. Oh, it's another broken ankle. Oh, it's another broken hip. But these are, for those people, and often for their friends and family, the worst day of their life. They see their livelihood disappearing, their ability to care for their friends and family, their ability to do sports, all those things suddenly they just can't imagine doing again. And so where I'm now like, yeah, it's another broken ankle, actually, you have to sometimes remind yourself that if you get brought in by ambulance in a cast, you've had your sock cut off, an ambulance had to come onto the football pitch, suddenly you're like, this is a big day for you. And I'm sure other people will cover it, but I can never be certain. So I am going to go over it again. And actually, the ABC approach to trauma will never, ever steer you wrong. Don't be afraid to go back to this. And orthopedics have this reputation for being kind of the knuckle draggers. And actually, I disagree. I think we are masters of kind of work smart, not hard. And if you stick with your ABCDE approach to trauma, you are unlikely to miss anything that's going to kill them, either in the first kind of couple of minutes, or more likely when they're under your care in the coming hours to days to weeks. Often orthopedics are asked to do the secondary survey. And when I'm asked to describe what a secondary survey is, I say it's an MOT. It's your review of systems. Personally, I would start at the head end and work my way down. Poke, prod, move, and if need be, image everything and anything. And the really common thing that you hear about is someone comes in having had a car crash and they get the full thing and the trauma team's there and it's all very rock and roll and the people in jumpsuits are there. And then everything calms down and loads of people disappear and you're the orthopedic doctor and you're kind of last person standing. And that's when the patient goes, I don't know if now's the time to tell you, but my wrist is really sore. And because they had neck pain and back pain and tummy pain and everything else, that's when you discover that they have a scaphoid fracture or a distal radius fracture, or they've ruptured their quads tendon or whatever it is. So secondary survey is something you need to remember to do after your airway, breathing, circulation, disability and exposure, because it's going to have a huge impact on the rest of their lives, because trauma and orthopedic surgeons are reconstructive trauma surgeons more than we are resuscitative trauma surgeons. We tend to not go around unzipping bellies and things, but it is important. So now, hip fractures. Day one, ortho one, the thing we see the most of. And it is where a lot of people, whether orthopedic or not, kind of do the eye roll of like, enough. But what we know is that actually 65 to 70,000 neck of femur fractures happen every year. Every year. And here's the bit that blew my mind when I became an orthopedic SHO, is you get used to consenting people. Yeah, pain, bleeding, infection, neurovascular damage, blood clots, etc. And you kind of, it rattles off the tongue. And then I remember my registrar when I was more junior being like, well, you need to consent for death. And you need to say death. You can't use a euphemism. You can't like waggle your eyebrows and say it could be very serious. You need to consent for death. And I was like, what? Why? And it is because a third of neck of femur fracture patients die in the first year following their neck of femur fracture. Now, that's not necessarily because they have an operation. It's not necessarily a sequelae of the operation. It is because of everything that happens afterwards. Their mobility goes down. Their ability to self-care goes down. Their ability to feed themselves, dress themselves, all those things that they're likely struggling with anyway if they're a neck of femur fracture patient. And as we know, and it is why we love our ortho-geri colleagues, neck of femur patients are, on average, a complex medical patient who also have a femoral neck fracture. It's not like, or it is uncommon that they are young, fit and healthy and got hit by a bus and have a neck of femur fracture. It does happen. More often than not, they have loads of medical comorbidities, which again are complicated by this significant injury. And 1/5 of them don't go back to their own home. So the social implication of a neck of femur fracture is huge. And most of that rests on our shoulders to sort out and to take care of. Important things to think about. I'm not going to teach you to suck eggs. I'm not going to teach you how to take a history, right? Hopefully you can do that. I'm an orthopedic surgeon. Even I can take a history. But actually, there are some real nuances to the history that you take and the way you manage these patients that will influence how well your patients do. So neck of femur fracture patients are managed as part of an MDT. It is that simple. Orthopedics doesn't work without all of our mates, both in the medical specialties, the nursing specialties, and the allied healthcare professionals. So you do need to ask all that stuff that, we joke about. You need to ask, do they have stairs at home? You need to ask how far they can walk. Can they get to the shops? Who does their shopping for them? Do they normally dress themselves? Do they have any pets at home? Where is the toilet in their house? Because all those things that you kind of did as a final year medical student when you did your 42-page histories suddenly come back to haunt you, because that is useful information when you speak to the physios, when you speak to the OTs, because the moment someone comes in with a neck of femur, because we're actually a positive bunch, we start planning for how to get them home again. And that means thinking about things like, well, actually, they live in a house with 30 stairs and their toilet is actually on the ground floor and their bedroom's on the 3rd floor. And that all requires you to ask those questions. Part of the MDT is our emergency department and anesthetic colleagues as well, because again, a lot of these patients have some complex needs. Now, most of the things I'm going to cover today are covered by something called, and please withhold the laughter, BOASTs. That stands for a BOA standard for trauma. They are hosted on the BOA website, and they are not only kind of the best evidence and standards we use for managing these patients, but often they're linked to tariffs. They're linked to money. So you need to manage your neck of femur patients, your ankle fracture patients, and so on in a certain way for your hospital to actually make money from these patients. It sounds awful, but it's something to think about. These are not just audit standards. When a patient comes in with a neck of femur, your first image of choice is an X-ray. However, you can't always see a fracture on the neck of femur X-ray, the AP and lateral pelvic X-ray. The best imaging, if the X-ray isn't good enough, is an MRI scan. But realistically, in most hospitals, that's not something we can achieve. Certainly not something we can achieve in 24 hours. So at that stage, you have to consider CT scan. And don't be afraid to do that. Correlate it with your clinical findings. So if their leg looks normal, their X-ray looks normal, but they give a history of having fallen over, and when you internally or externally rotate their leg, or you axial load it, that is to say they have a straight leg and you push on their heel and they say, ow, if you're worried, get a CT scan. Neck of femur fractures hurt like hell. The femur of a normal, fit and healthy adult has the same mechanical properties as concrete, right? It takes a lot of energy to break a hip. In most of these patients, they're osteoporotic. It's not the same thing. However, it takes a lot of energy to break a hip, and they bleed. And they've often been on the floor for ages. And there are loads of muscles in the hips, pulling it left, right, here and there. So not only do you need to check how much pain they're in and give them adequate pain relief, you need to keep doing that, because you can't just keep hitting them with morphine in the hope that they don't complain. Their pain is going to change as they get better, as they get more hydrated. And it might be that they need a fascia iliaca block, which is often done by the ED doctors, but sometimes by anesthetics or the orthopods. You need to fix them, and you need to fix them soon. The classic orthopedic stereotype, again, is the sort of, they have a fracture, I need to fix it. But the fact is that certainly in neck of femur fractures, we have really good evidence that fixing these patients sooner keeps them alive, and that delays beyond 24 to 48 hours, depending on which paper you read, significantly increase morbidity and mortality. So it's not that there's a rush to fix them, but the goal is to fix them soon and to get them as fit as possible, with the recognition that you're not going to suddenly cure someone's years of heart failure or years of this and that and the other. You're going to make them as well as you can, and then you're going to fix their hip so that they can walk again. And that's the important bit. That morbidity and mortality I was talking about happens after the orthos do their bit. I always say to my patients, I'm going to do the easy bit. I'm going to fix you. Then the hard work starts. So that's why you have to already involve the physios, the occupational therapists, and you should have some sort of orthogeriatric or medical support, because they are complex patients. Your neck of femur fracture will often come in collapse query cause, confusion query cause. It is very easy to go, yeah, well, they're a confused old lady. Don't. Keep an eye on their delirium and their dementia. Monitor it. Do mini mental state exams, and don't be afraid to go back and reassess. Why are they confused? Is this a chronic condition? I spend a great deal of my time on call having conversations with families and GPs about their pre-morbid state. Don't assume just because they come in confused, this is how they always are. And then it's about managing their risks, because the only thing worse than a broken hip is breaking the other side. If they fell, chances are they're at risk of falling again. Adult hip x-rays are not easy to look at if you're not used to it. There are a couple of things you can just do. And again, I'm not going to go into an exhaustive radiology teaching session, because there just isn't time. My basic advice for looking at x-rays, if I'm honest, is compare both sides and use your eye, use your pen, use the computer mouse, and follow the edge of the bone. So hopefully you can see my mouse. And what I would say is, I, with my eyes, literally follow the edge of the bone. And you want to look for a breach in the cortex, right? Something that doesn't look right. And that's a really simple trick for looking at x-rays. If you're not sure what you're looking at, is just looking at it and going, does that look right? Does that look normal? Does that look like how I think a bone should look like? If you're not sure, ask someone. Shenton's line is your friend. Shenton's line is this. If you imagine an imaginary curved line going like that, you can see it on this side here as well. It is often disrupted, as you might imagine, by a neck of femur fracture. So one of the things you can say to your registrar, your colleague, is Shenton's line was disrupted. Equally, if it's not disrupted, it kind of gives you a certain amount of confidence that there's either nothing there, or more likely, if there is something there, because they've called you, that it's undisplaced. So you can see here, you know, when I talked about like following that line, it just doesn't look like a smooth thing. There's all kinds of lumps and bumps in the way. And that's because there is an intracapsular neck of femur fracture there that is disrupting Shenton's line. This is like trauma meeting 101, but it's also why we need you to know a little bit of anatomy. The whole thing with neck of femur fractures is around the blood supply to the femoral head. And it's because if the femoral head dies, you get avascular necrosis, you get pain, you can't move. So our goal is either to fix it so that the blood supply doesn't fail, or accept that the blood supply is gone and replace it. Most of the blood supply to the femoral head comes from the medial femoral circumflex. There are other bits and bobs like the ligamentum teres and so on, but the big blood supply comes from the medial side. And when you look at this diagram, hopefully what you can see is, and what you can visualize is, that if there is a fracture here through the femoral neck, it's going to pretty much cut off all the blood supply going into the femoral head. So if it is intracapsular, because the hip capsule attaches just here, if it is intracapsular, there is a very, very high chance that this femoral head is going to die. Whereas if it is extracapsular here, there is a possibility that some of that blood supply is still going to be there and the femoral head stands a chance. Also, that is now very much how we describe femoral neck fractures. So if you were calling me and you said, hey, Simon, I've got a patient with a right-sided intracapsular neck of femur fracture, I know what you're talking about. I don't need you to give me loads of detail about this, that, and the other. Or you can say, well, actually, Simon, it's extracapsular. I know what you're talking about. And it's all actually related to the blood supply. And often that is how we make our operative decision too. And our operative decisions are many. So these are where we are trying to fix the fracture in the hope that the femoral head survives. These are cannulated screws. This is a femoral nail, and this is a DHS, a dynamic hip screw. And they are all for fractures that we think we can fix, and we think that the femoral head can survive. So here, for example, this was an undisplaced intracapsular fracture. So we're hoping that the blood supply is okay, but we're going to keep a really bloody close eye on it. This, on the other hand, is a nasty comminuted in loads of pieces extracapsular fracture, which is why we're going to use a nail to hold it together and hope that the blood supply survives. This patient had a fracture like I showed you on that previous x-ray. There's not a chance that that femoral head would survive, so we have replaced it with a hemiarthroplasty. The one thing I haven't shown here is a total hip replacement. If the patient is fit and well and can walk normally, there are guidelines out there that say there is a role for total hip replacement in femoral neck fractures. Be aware that this is not a neck of femur fracture. For those of you who know their anatomy, you'll notice that the femoral head has drifted somewhat into the gentleman's scrotum. There is a difference between a neck of femur fracture, which is generally a fragility fracture seen in the elderly, and this, which is a proximal femoral fracture as a high energy injury. They very much are a different cohort of patient. Your operative goals are, as you can see here, still the same. You want to fix it. You want to give it the best possible chance of that femoral head surviving. But the fact is that this is not a patient who's going to need, confusion scores and all the rest. This is a polytrauma. This will have come in with HEMS and all the rest. So neck of femur fractures are very much a distinct population. Ankles. The thing you need to know about the ankle more than nearly anything else is that there are 4 really common mechanisms. And that's all to do with the biomechanics of what happened to the ankle when the break occurred. And whether it was adducted, abducted, external rotation, supinated. And you've just got to imagine someone's ankle moving around in that way. Okay, and you've got to imagine that as they move in a certain way, different structures will break, both the bony structures and often more vitally, the ligamentous structures that hold the ankle joint in place. That's again why your history is so important, because your patient will say, well, I was on the football pitch and I had my foot fixed and I went to turn, but my studs were fixed in the ground. And you already know what you're going to see on the x-ray because of the history you've taken. But also, if you're more interested in the operative management, you can start to imagine whether they've ripped the medial or lateral ligaments or the syndesmosis, the ligaments in between the 2 bones as well. Mechanism is key. The other things you need to note as an orthopedic doctor are around the quality of the skin, the state of their circulation, and their sensation. And that goes for all injuries. If A&E are already talking about chucking it into a cast or wrapping it up, you either want an A&E doctor who is experienced enough to tell you about the skin, the circulation, and the sensation, or you need to be pretty assertive and say, I need to see those things before you chuck it in a cast. Anything that looks like this needs to be reduced. There used to be an argument that you should never see an x-ray like this. It was kind of dogma that you should never see an x-ray of a fracture dislocation. What I would say is, and the guidelines agree with me, is you should get an x-ray unless it will cause an unacceptable delay. There is debate about what that means. So in other words, if a patient comes in, their foot is white, pulseless, the bone is sticking out of their skin, it's been like that for hours, there's an argument that with appropriate analgesia, you should just get on and do it. Equally, if a patient comes in having fallen over on the football pitch, they have an ankle that's potentially very swollen and nasty looking, it looks like this, it needs straightening out. Yeah, get an x-ray. You have time. And actually the x-ray is going to tell you, as we said, what bony and soft tissue structures have been damaged and therefore what you need to do. Important message is get another x-ray before you let them leave the emergency department. You do not want to see an x-ray in plaster that still looks like this when they're up on your ward. You are within your rights to call your registrar if you need, to do whatever you need to do, but no patient should have a manipulation of any kind and leave the emergency department without an x-ray. So, some fractures are stable. One of the most common classification systems you'll hear about in the trauma meeting, and this is why you should know about it, is the Weber system, which talks about where the fibular fracture is in relation to the ankle joint and to the syndesmosis. That is, the things holding the fibula to the tibia. Weber A is at or below, Weber B is at, and Weber C is above. Weber A's are classically stable. Weber B's and C's, again, it depends on what else you're seeing. A stable fracture needs a painkiller, needs to be put in some kind of splint, whether that is a cast or a boot or whatever. And here's the brave thing: stable fractures can weight bear. If you're not sure, ask. Don't send someone home walking and say, yeah, you can walk on it, and the next day have someone go, what have you done? So if you're not sure whether it's a stable fracture pattern because of the biomechanics, the anatomy, and all the rest, ask. Nearly all ankle fractures should be followed up in a fracture clinic. Your hospital will have a fracture clinic policy. Do not be afraid of sending patients to fracture clinic. Again, your senior colleague will be able to advise you on whether you have a local policy for within 48 hours, 72 hours, a week, next available. And again, that will be decided on very much by the fracture pattern. Here's the thing, and these are the ones that catch people out. This could look pretty stable. It's only when you notice that there's an increased gap there that you suddenly realize that that must mean the syndesmosis has been damaged. This patient probably needs an operation, even though it'd be very easy to go, yeah, well, just send them home. But it might be that this patient can go home, but be discussed the next morning in the trauma meeting. So again, your hospital will have nuances around, for example, what patients can go home and what patients need to go on the ward. In terms of patients that you need to kind of have your spider sense looking out for, I would say anyone with a talar displacement. This is your talus here. There should be a nice even space, like you see here, all the way round. So if you see some asymmetry, phone a friend. Don't be afraid to reassess it in a plaster, because it may be that you put them in a plaster and it goes from this to this, at which point your registrar or your consultant might go, actually, let's see them in clinic and see how it goes. It may be that they decide to fix it. Any sort of displacement, any sort of comminution, anything where it's open, chances are they're going to need some kind of operation, some kind of fixation, either with a plate and screws, an external fixator, something. The goal of fixation is to reduce the joint so that that syndesmosis comes back, to get the fibula out to length so that it looks like a fibula again, and to make it stable. Now, there's some controversy. The guidelines say this: most of your patients should be allowed to weight bear as tolerated after their operation, unless you are concerned about your fixation or you're concerned about the patient, which is sort of the get out of jail free card. What that means is that you, as a more junior doctor, if you're doing their TTA or what have you, you need to be really clear on what their mobilization advice is. Because it used to be that all ankles were non-weight bearing for 6 weeks. And that's just not the case anymore. Now we try to mobilize these patients as soon as possible. A, it reduces their risk of DVT. B, it just means they can get back to normal life. And C, it means they have less stiff ankles when they eventually come out of whatever immobilization they have. However, if they are an alcoholic diabetic with peripheral neuropathy, chances are you're going to make them non-weight bearing, because they won't have that feedback system that tells them that their ankle hurts and they need to put their foot up for a while. Wrists. Wrists are a tricky one. And that's because, again, they can look pretty simple, but it's only when you follow the line that you realize that that's a bit of the joint surface down there. This is a lateral view, and you can see the joint clunks down there. And then there's another bit of the joint surface there. And yet, when you look at the AP, it kind of looks sort of smooth. You could convince yourself that on the AP view of the X-ray, the joint surface is fine. You could convince yourself on the AP view of the X-ray that actually this wrist is okay and going in a cast, no harm, no foul. But it's only when you start to really look at this X-ray and think about it and go, wait a second, that ulna is longer than that radius. And it's because the whole joint surface has been squashed down. And actually our goal again in the operation is, both in the lateral view and in the AP view, to restore not just the joint surface, but the length as well. And it's something that, again, I used to get really confused by, because of course there's lots of joints in the wrist, because it's not just a joint between the radius and the carpal bones. There's also a joint between the radius and the ulnar. And actually the radius and the ulnar both impact the elbow. So a lot of these injuries in young people that we used to go, well, it's just a broken wrist, can have huge implications for their life and their work if you don't quite manage them the right way. Don't be afraid to look at two views, and don't be afraid to Google these little measurements. This again is one of those trauma meeting questions you get asked a lot. And it's about looking at both your AP views and your lateral views. Because again, if you look at this on the AP, you go, well, I guess that's a bit short. But then you start to look at it and you see that there's a big hole in that joint surface. And you start to look at it again and you think, that ulnar nearly is longer than the radius. Oh, crikey. Okay, fine. Maybe that's something I should care about. But then when you look at this, you realize that that's the joint surface. That not only is there a big old gap there, but it's pointing volarly in a way that most people can recognize it just shouldn't. The nice thing about the measurements and numbers and things that we ask about in orthopedics for wrists is that they're all sort of related. So it's 11 degrees there for your radial or your dorsal or volar tilt, and it's 22 degrees there for your inclination. So again, if you're looking for a 22-degree angle there, yeah, it's not there. Whereas if you look at this post-op, you can see what I mean by that 22-degree restored inclination. And similarly, you can start to see that 11 degrees there that we've restored there. The classic history you'll get is a fall on outstretched hand. And without going into too much detail, again, it's important that you ask how they landed on that hand. Was it with their wrist flexed? Was it with their wrist bent? Was it with, because you can then start to work out what bits they've broken, what took the most force, and why you're going to need to fix or not fix certain things. And that's because everything articulates with everything else. The distal radius articulates with the scaphoid, with the lunate. So that's your scaphoid there. That's your lunate, right? But also it articulates with loads of other stuff. And there are loads of ligaments joining the radius up with the ulnar. Conflict of interest, I'm an upper limb surgeon, I want to be a hand surgeon. I always like to think of the wrist as an upside down ankle joint. If you start to think about this as a tibia and this as a fibula, you're like, oh, crikey. Because people used to ignore these kind of injuries. But if you think back to those ankles I showed you, if that was someone's ankle joint, you'd be like, bloody hell. But it's a wrist, so people sort of shrug it off. Same. In fact, if it was mine, I'd worry more about my wrist than my ankle. Colles fractures are what you're going to see a lot of. Wrist fractures make up about 17% of all fractures in the adult population, and Colles fractures in particular make up about 10% of all the broken bones that come through your emergency department. It's an eponym, right? We love our eponyms. There's Colles and Bartons and Smiths and all the rest. Google to your heart's content. A Colles fracture is very specifically a fracture of the distal radius with that fragment dorsally displaced. Okay? It is a fragility fracture, like calling it a neck of femur fracture. So this young patient, that's a distal radius fracture. It doesn't matter. That's a Colles. You may be asked to reduce Colles fractures in your emergency department, or at least help out in them. I would absolutely encourage you to get involved. It is a great life skill to have. I'm not in a position right now to do a whole session on how to manipulate Colles fractures. But what I would say is, whether it's wrists or ankles, if you can learn how to manipulate the basic fractures and how to put on a really good cast, you are on to a winner. I would encourage you to spend as much time as you can in the plaster room. Get taught how to put a good plaster on. So here's the debate. There are some big studies coming out that it's unlikely you'll be asked about, but you should be aware of, about whether we fix too many wrists. Chances are we do. What we would say is, a bit like ankles, we're learning now, just like ankles, that actually stable fractures that are extra articular and either minimally or not at all displaced, can be mobilized or might need a removable support, a splint. Sometimes, for whatever reason, you might need to put them in a plaster of Paris. And if that's the case, don't be afraid to say to whoever's doing the plaster, look, I'd really like you to put them in neutral flexion. Okay, so that's with the wrists slightly bent. Don't be afraid, if you have to have it slightly bent and slightly ulnarly deviated. In a patient who is over 65, so without being ageist, it's really about the kind of demand they're going to put through their wrist and about their likely bony quality. Non-operative management is the most common management for most of these fractures, unless it's really, really deformed. You can live with a bent wrist. This is a nice example of a fracture that you might, to look at, think is one for non-operative management. But actually, you can suddenly see that, yeah, it's a Colles. There's that displacement we were talking about. Now, it might be that all it needs is a manipulation in the emergency department. That might be all they need to save them having an operation, a procedure. Because if you can correct this angulation a little bit and make this a little bit longer, chances are you're going to save them an operation. If they're going to have an operation, we talk about K-wires or plates. K-wires look like pencil leads. They're just pointy pins. Plates are the orthopedic plates that you've seen on my previous x-ray. If they're really, really displaced after a manipulation, if they're in pieces, if they're really comminuted, then you have to think that that wrist is unstable, and then you need to think about fixing them. That doesn't mean they need fixing, whereas before we used to be very much like, oh my goodness, it's comminuted and displaced, let's fix it. More and more we're thinking about, well, do they need an operation? The theory with K-wires are, because they're percutaneous, we put the pointy end through the skin. If you can fix it without opening the skin, use K-wires. If you need to make an incision, then you should probably use a plate, because once you've decided an operation, you want to give them a good result. This is what a K-wiring operation looks like. These will have been done without an incision. They are holding that bone in place. Those wires will then be pulled out at a later date. This, on the other hand, needs a plate. That can't be held with wires. That decision was made. Job done. Open fractures. You may see open fractures during your orthopedic placement, and you should start to get an idea about how to manage these. A third of all patients with open fractures have another injury, but this is what we call a distracting injury. That is to say, if they're screaming the house down and swearing blind, they're not going to be aware that they have a ruptured spleen, that they have a fractured scaphoid, that they have a nasty scalp laceration. If your leg looks like this, you don't care about the other stuff. These fractures should really go to a major trauma center and be managed by an MDT. They don't always go to a major trauma center, though. Be aware, keep an eye out for them. It used to be that these would get operations in the middle of the night. It's just not the case anymore. The evidence suggests you don't need to rush to fix them. On the other hand, there are certain things that you want to do sooner rather than later. So, for example, you want to get antibiotics into them as soon as possible. Again, this is another one where there's a BOST, a BOA guideline. There's BOSTs for all the stuff I've spoken about today. You want the antibiotics in an hour or less, ideally. Generally, that's augmentin, coamoxiclav. There are guidelines out there. Your trust will have guidelines. You want to give it a clean. That is to say, give it a good wash and wash away gross contamination, right? If there's a twig sticking out of their leg, you may remove the twig. There's really no role for debridement or washouts in A&E. Just give it a good clean, get rid of the badness. Take pictures. Your A&E, your hospital, your orthopedic department should have a departmental camera and have policies about how you take those pictures and upload them to some sort of confidential, resource. Your hospital may have a policy on using smartphones if that's not available. Ask around. The point is, once this is all wrapped up, it's very hard to describe the injury to your colleagues, to the plastic surgeons. You're like, well, their bone was sticking out their leg. It's a lot easier to just show them a picture. Cover the wound or wounds with saline-soaked gauze, not betadine. Betadine dries hard and sticky and mixes with blood to like glue, like concrete. Saline-soaked gauze. Then it's a matter of fixing it, debriding it, and closing it. That is an orthoplastic case. Plastics need to be involved from the get-go, even if it's so they can say, yeah, you can handle this. We're happy for you to manage this. Because sometimes they will, sometimes they won't. Sometimes they need something called a fix and flap, whereby orthopedics do the debridement as needed, fix it as needed, and then plastics come in and cover it in a skin flap, a free flap, whatever. The goal is that regardless, you should really try and have skin closed within 72 hours. That's the goal. That is going to reduce infection. And again, that works if you involve the MDT from the get-go. Which leads nicely on to compartment syndrome. It is a surgical emergency. This is one of the few things that orthopods will do in the middle of the night. If you're not sure about a compartment syndrome, chances are you need to be making some phone calls quickly. This is a picture of a compartment syndrome I dealt with. I use all of my pictures with permission. This is a really nice example of a patient post-tibial nail. And you can see that this all looks happy and healthy and bleedy. And this all looks like dead raw chicken. This was 2 hours after his operation when I got a phone call saying the patient's making some noise. The reason being is that time is muscle and time is nerve. So by the time that they're making noise, if you've got an hour, maybe 2 hours, 3 to 4 to 5 to 6 hours, you're into real danger zone. 8 hours, whatever's dead is dead and going to stay dead. So with a compartment syndrome, you need to be thinking about moving quickly. This is the sort of thing that you don't get to say, yeah, I'll get to it. This is a thing that you go to. There are multiple things that can cause a compartment syndrome. Open or closed fractures. Just because the fracture is open does not mean it is any less of a risk of compartment syndrome, because you've got to imagine that muscle is still wrapped in that thick fascia. Just because it's got a little hole in it doesn't mean it can't still swell within that fascia. Any sort of direct blow or crush. So, if someone says, well, my leg got trapped between my car bumper and the wall, but there's nothing broken, there's a really good argument for keeping that patient in overnight just to keep an eye on them. Your patients who are on warfarin and dabigatran and all the rest, they're at risk of compartment syndrome because their risk of bleeding is so much higher. That risk of kind of slow ooze. Reperfusion injuries are really, really high risk. And the other thing is just tight bandages, tight dressings. So one of the first things you do is take all the dressings off, down to skin. Even that stuff that looks and feels like cotton wool, it's got to come off. Your signs of compartment syndrome. As far as I'm concerned, signs of compartment syndrome are pain, 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 and pain. All the other P's, you've missed the boat. Pain out of proportion. So if you have a broken leg, it is not surprising if you're in pain, right? If you have a broken leg and your leg is elevated, you're not moving the leg, and you've had some morphine and codeine and you're still screaming, that's out of proportion. Pain on passive stretch. So you're stretching the muscles in that compartment. So you, the doctor, are wiggling their toes or wiggling their fingers, and they are screaming. Once you get into the realms of tense compartments, paresthesia, paralysis, cold legs, that goes back to my previous slide. you're already into the realms of either irreversible damage or at least, oh my goodness, we're going to have to see how this plays out. Your early signs are pain. Everything else is late. It's important to know the anatomy, and it's why when we as surgeons do operations, we try and do them around the incisions for a fasciotomy. In fact, when we debride open fractures, we try and create incisions, if we need to, that are around our fasciotomy incisions if we have to. And that's because if you look at this diagram on the right, with 2 incisions, we can access all of the compartments of the lower leg. Fasciotomies are big incisions. They have to be to relieve the pressures. And so one of the big questions will be about the landmarks for a fasciotomy. And it is about being guided by the tibia, your tibial border, with your posteromedial incision, 2 centimeters or so posteromedial to it, and your anterolateral decision, 2 or more centimeters anterolateral to it. It is now time, you lucky, lucky people, for a bit of a quiz. So I'm going to give you a chance again, and then we're going to go down the links. So which is not a principle of open fracture management? Should you take pictures? Should you give them antibiotics? Should you debride them? Should you stitch them up immediately down in A&E? Or maybe in the operating theatre if you're feeling generous. It's immediate wound closure. There is no role for just stitching people up. They need to be properly managed, but they do need pictures, antibiotic cover, and they need to be debrided. So in a neck of femur fracture, is their leg going to be short and externally rotated, short and abducted, short and internally rotated, short and adducted? Think about the muscles. Where are they going to pull the fragments? Think about how those patients are lying when you see them from the end of the bed. Their leg is going to be short and externally rotated. Their foot's going to be pointing outwards. Short and internally rotated can be a sign of a dislocated hip, so keep an eye out for that. An early sign of a compartment syndrome, a pulseless leg, the patient saying that it's numb or tingling, pain on passive stretch, or a paralyzed limb that they can't move. Pain on passive stretch. Pain, 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 and pain are your early signs. Everything else is late. Main supply to the femoral head. Trauma Meeting Quiz 101. It's the medial femoral circumflex. Medial humeral is a whole other limb, so yeah, it's not that. And finally, you've got a 70-year-old. They've got a Weber A ankle fracture, and otherwise they're fit and well. Do we take the leg off? I mean, I guess that would solve their problem. Do you not operate on them and get them walking? Do you not operate on them and tell them to stay in bed, keep their leg up for a couple of weeks? Or do you fix them, ideally within 72 hours? Yeah. If it is a stable ankle fracture and they've got no other problems, treat them in a cast or a boot, get them walking. Hopefully, all of the outcomes have been covered. Don't be afraid to access the BOA standards for trauma. They are your friends. Another resource you might find useful is a website called Orthobullets, which is really, really handy if you're doing orthopedics. Trainees use it from SHO level up to exam. It offers as much detail as you do or do not need. And I wish you the best of luck. Now let's see how we're going to do Q&A.
Simon, that was great. So we do have some questions that have come up.
Yeah.
And so they kind of vary in terms of being simple questions to a few more complex ones. Let's start with one of the simple ones. So it's asking, some diagrams mentioned the term volar. What does volar mean?
Jargon, see, fired, day one. So again, it's one of those terms that we like to use a lot. The way I like to think of it is you've got the classic Vitruvian man, right? The Da Vinci bloke with like the arm stuck out to the side. That's the anatomical position. And then I always used to think about dorsal. The dorsal fin is on the back of things. So if this is my arm, this is my dorsal surface because it would have a dorsal fin. It is the back of my arm. And therefore, by definition, this is volar. It is the front of my arm, which is different to saying, say, anterior. And so you'll hear that a lot, dorsal or volar. And that's about the anatomical position.
Fab, thank you. Another question is asking, I'm worried about trying to reduce a Colles fracture. Do you have any no-goes or big mistakes that can be made?
Yeah, loads. Number one, you shouldn't ever be doing it without a buddy. Ideally, someone like me who likes to teach and has done a bazillion of them. My general rules are they take more time than you think. You need really good analgesia on board. So that's gas and air, morphine, some local anesthetic, maybe even for some things, kind of intravenous sedation, if your department are competent to give that. But the biggest problem people have with reductions, whether that's wrists or ankles, is rushing. So the first thing I do whenever I'm doing any kind of reduction is I put them in traction for a couple of minutes. So that's why you need a buddy, because you need to pull on that limb for a good couple of minutes to let all the ligaments and things relax before you try any kind of reduction maneuver. They are one of the most satisfying things to do in orthopedics, reductions down in ED, but only once you've sort of gotten comfortable with them. So I would say don't worry about them, because you just shouldn't be doing them without a more senior person kind of supervising you and talking you through it.
Great, thank you. So another question we have is a Colles fracture dorsal displacement of the wrist?
So a Colles fracture is an eponymous fracture where the distal fragment, so that's the broken bit, is volarly displaced, right? Because they've fallen like that, right? They've fallen on outstretched hand, as you might imagine. So this bit of their wrist is pointing volarly.
Fab.
Sorry, dorsally.
Yeah, we're getting quite a few questions. Are you happy if we try and go through?
Yeah, I'm not. I've got nowhere to be if you guys are happy.
Thank you.
Makes me sound really sad.
So this is from Dr. Parv Mittal.
Yeah.
Patient with severe pain and swollen leg with fracture both bone legs. Pulse is palpable, no paresthesia. Yet, do we observe and monitor, or do we inform the registrar and plan fasciotomy?
So give me the history again.
So, sorry, it's I think it's like one sentence. Patient with severe pain and swollen leg with fracture of both leg bones. Pulse is palpable, no paresthesia.
Yeah, so that's a really good example of one where, and what I would say is you don't just call the reg, right? And this was something that, again, I always feel quite strongly about. Like, you're a doctor, don't be afraid, go and see the patient, because they might be in 5 out of 10 pain. They might just be like, it's quite sore, doc, Well, is it better than it was? Yeah, actually, it is better than it was, but it is really still sore. Okay, fine. So go and see the patient, assess them. If their pain is out of proportion to their injury, right? So you get down there, they've got a fractured tib fib, and they're screaming, and they're in agony, and you take the cast off, you take all the wrapping off, and they're still screaming, and they've got morphine on board and everything else, and they're still screaming, and you wiggle their toes, and they're screaming. Yeah, you call the reg, and you say, I'm worried this is compartment syndrome. But you need to have laid eyes on the patient, taken the cast and the bandages off, assessed the patient yourself, so that you can make a value judgment, and then you call the reg and go, I am worried about compartment syndrome. And then the senior will come down and will make a decision. And sometimes it's let's keep an eye on it, and sometimes it's take it to theatre. That's a bigger, scarier decision.
Okay, fab. And actually in line with that theme, another question is asking, do F2s or other juniors sometimes do fasciotomy on the wards if seniors are in theatre?
No. That is, or at least I've never heard of it or seen of it. It's kind of a back in my day story you hear about. There is no role for you doing a fasciotomy on the ward. What I would say is there are very few times you can't find someone. If your reg is scrubbed and you call up and you're like, so number one, like it's on-call 101, I would advise you do all of your on-calls in scrubs, and that's so that you can go into the operating theatre. So if you come into my operating theatre and you're like, Simon, mate, patient on in bed 4 with, bimalleolar ankle fracture. They're screaming the house down. They've got pain on passive stretch. I am really, really worried they have a compartment syndrome. I'm going to descrub, or I'm going to tell you to find the consultant, or I'm going to tell you where the other consultant already, like, that's your best bet. Don't be doing operations on the ward.
Fab. And another question is, you'd mentioned that plastics are involved with reconstructing open fractures. At what point do you know if it's appropriate to involve them or to close the wound yourself?
That's a really good question. Often that's a decision you make with both your senior and often the plastic surgeons. So for example, if there is, so really you don't know till you've done your debridement, right? Which is where you basically unzip whatever's broken and clear out all the badness. But for example, if you have a broken wrist and there's a tiny cut on the wrist that goes down to the bone, chances are orthopedics can manage that. If you have a horrible injury where it's covered in horse poo and all that other stuff, chances are you need plastics. And that's why you manage them as an MDT from the get-go. So we will often talk to plastics from the get-go. And again, your senior might say, yeah, plastics, we're just giving you a heads up, but we're good. Or your senior colleague might say, we don't need to tell plastics about this. This is fine. And sometimes it's you tell them and you say, we're going to want you to come into the operating theatre once we've done our debridement and advise us on what to do. Because sometimes plastics will go, yeah, you can put a vac dressing on that, or yeah, you can close that up. And other times, before they even go to operating theatre, you've made a plan. So there's no hard and fast rule. It's about involving your seniors and their team early.
Great, thank you. We have a question regarding compartment syndrome again.
Yeah.
Do you have to measure the pressure of compartments in every case?
No. So compartment syndrome monitoring is something that you should be aware of, but is unlikely you will have to do. So there are these little things, they have a needle on them hooked up to a manometer that will tell you the pressures in the leg. Compartment syndrome monitoring is very useful in patients who can't tell you that they're in pain. So that is non-communicative patients for whatever reason. So for example, if you are managing a polytrauma patient and they have a horrible lower limb polytrauma and they're on ICU and they're intubated and blah, 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 blah. And that's one where you might be wanting to monitor their compartments. Also, sometimes we might just do fasciotomies anyway. There is no role at the moment, and certainly I wouldn't do it, for kind of compartment pressure monitoring as standard. It is often a clinical diagnosis.
Fab. And our last question is asking, do you know of any good courses that you'd recommend for basic ortho management for procedures such as knee aspirations and fracture reductions?
There are loads actually, and it depends. So a lot of hospitals do their own. I know, for example, the Royal London does a course literally for that. It's like, orthopedic SHO core skills or something. I know the Royal College does a lot of them, the Royal College of Surgeons. So I would ask around locally, see if your hospital just does them. And if not, I would look at the BOA, at BOTA, the British Orthopaedic Trainee Association, and at the Royal College of Surgeons. They are like the three big hubs for courses.
Fantastic. So that's all we have for our Q&A. So with that, our webinar is going to come to an end, and I'd like to say a massive thank you to Simon.
My absolute pleasure.
Wonderful. And if you do have any further questions, then feel free to email us, and our email address is currently on the screen, and join our mailing list. So if you do want to get a certificate of participation, which we're working hard to get to you guys, please complete the post-course questionnaire. That's going to come up on your screen as soon as you finish the webinar, but you'll also get an email about it in the next day or so. And just to say a massive thank you to all of our viewers for coming as well, either if you're on Zoom or on YouTube. Thank you. So one notification just before we finish is that we were due to have a webinar next week for general surgery. However, we've had to sadly cancel that webinar and postpone it for a future date. This is due to our speaker, unfortunately, having quite a few clinical priorities. But rest assured, we'll have our October schedule released very soon. So if you do want to keep track of that, then be sure to follow us or join our mailing list, and keep a lookout on Twitter, Facebook, or Instagram for that to turn up. And with that, again, thank you so much.